You're all set.
Okay. Okay. Good afternoon, everybody. Welcome to the annual meeting of the Appalachian Node. The first one was held last year in Pittsburgh. Now it's West Virginia's turn. And there we go. Nope. The advance is not advancing. Oops, I'm sorry.
There you go.
Ah, great. Okay. There's our welcome slide. All right. I want to take this time to tell you a little bit about our node and then to tell you a little bit about West Virginia. Hopefully that will spur some thoughts about future research and collaboration, because we sure have a lot to deal with here. And welcome for your attention. So here's our agenda for today. I'm going to get to start. Then Dr. Carters is going to talk to us about opioid and methamphetamine research in rural Oregon. And Spot Podoraki is going to show the video she made. We'll have a break. Dr. Shoptaw will talk about methamphetamine, evidence-based strategies for treatment. And we're going to end the day with a panel discussion, the future of intervention in substance use disorder, envisioning innovation. And here are our four speakers, and actually 5 speakers on 4 topics. And talk about new therapies, get a report from the people who run our local syringe services program, talk about integration of care, and end with one of our addiction psychiatrists talking about clinical needs. Okay. So here we are. This is our logo, the Appalachian Node. We are located here in central Appalachia, from the entire state of West Virginia and the whole western central chunk of Pennsylvania. And we have 3 institutions: Penn State, WVU, and the University of Pittsburgh. And I share the leadership duties with Dr. Liebschitz from Pittsburgh. He's a general internist whose research interests are in opioid prescribing and linking hospitalized patients with opioid use disorder to care. And I am kind of renegade person with a foot in 2 camps, one in behavioral medicine and the other in infectious diseases, because I am indeed an infectious diseases physician. And I am interested in the medical and social complications of injection drug use, and pretty much focused these days on public health. So this is a map of all the CTN sites. They're called nodes. Don't ask me why, but that's the rubric. And we are one of 5, those are the red stars, that were funded in the last go round. And that was an RFA that really put an emphasis on sites that could do research in rural communities. So we are joining the larger group in that context. And the Clinical Trials Network celebrating its 20th anniversary, very exciting. And the Clinical Trials Network actually got started as an effort to bridge the gap between research and practice. And as you can see, it was kind of spurred by an Institute of Medicine report in 1998. So to that end, this is the model for how the NIDA CTN works. NIDA folks have a significant role in all of this. We have investigators who are part of academic research consortia. We have investigators who are part of practice-based research networks in the community. We have studies that are situated in general medical settings and in specialty care treatment programs, linkages between those two, and really with the goal of integrating substance use disorder care. And our key clinical partners are threefold: the University of Pittsburgh Medical Center, which is enormous, 41 hospitals. Ooh. And they also have the Western Psychiatric Institute and Clinic. Here at WVU, we're somewhat smaller, 13 hospitals in the network, 6 affiliated hospitals, many in primarily rural settings. We have our practice-based research network and the Chestnut Ridge Center, which is our psychiatric hospital and outpatient clinic. And then Penn State, where co-investigator Sarah Kawasaki is in charge, is a network of 6 hospitals covering 7 counties in central Pennsylvania, 28 primary care practices in that area, and the Pennsylvania Psychiatric Institute. So this node encompasses both rural and urban sites. We got a nice mix. Here's what we've been doing. These are the trials that are underway. Everything, of course, got very slowed up in this past year because of the COVID pandemic. But the earliest studies I think that we started enrolling in was in July of last year. So we have MOMS, CTN 80, which is treatment for opioid use disorder in expectant mothers, a study that is underway at in Pittsburgh. We have CTN 99, which we're doing both in West Virginia and Pittsburgh. The emergency department initiated buprenorphine, and it has taken some real effort to screen people and get them randomized, but we are working hard at it. We have CTN 100, which is the optimizing retention, duration, and discontinuing strategies for opioid use disorder pharmacotherapy, which is a mouthful, and which is, we use the acronym RDD, and we're waiting for this study to start. But we, again, have 2 sites, one in Pittsburgh and one here in West Virginia. And then CTN 101, subthreshold opioid use disorder prevention, or the STOP study, is a conjoint effort of Pittsburgh and Penn State. And that has gotten underway and has been enrolling and has done a pretty good job. We're getting close. We've also made some significant contributions, I think, to the leadership of the CTN and the scientific direction of the CTN. We have been involved in the establishment and co-chairing of 2 new, what they call scientific interest groups, or SIGs, in the CTN. So my colleague here, Erin Winstanley, is the person who developed and co-chairs the Rural SIG, which is focused on the issues and concerns of doing research in rural communities. And I co-chair the comorbidities SIG, which is kind of a renamed version of the old HIV SIG, but rather than focusing on just one infection, the comorbidities SIG now includes all of the infections that are associated with drug use, and in addition, other medical and psychiatric comorbidities, so overdose and mental health concerns. We have really, for a relatively small node, have very active investigator participation in various SIGs and work groups. So Jane Liebschitz did a wonderful job of chairing the recent fentanyl work group, and Sarah Kawasaki and Laura Lander are part of that. Sarah and myself are also part of the Rural SIG. Jane and Sarah are part of the methadone task force, and Laura and Sarah are members of the stimulant research task force. So we are, we're doing our best to sort of infiltrate the systems of the CTN. We have so far had 1 study proposal submitted by our node, and that was by Dr. Kawasaki, who submitted a proposal to use microdosing to transition fentanyl-dependent individuals to Suboxone for opioid use disorder. And she got a lot of useful feedback from the CTN review, and we'll be starting a pilot, got IRB approval finally, and we'll be starting a pilot study at Penn State. So we're really looking forward to that. So that's kind of a summary. We're really just now entering our 2nd year. So it feels like despite the pandemic, we've done a fair amount for a new node. So I want to segue now to talking about West Virginia. And as I said in my opening remark, West Virginia really is the belly of the beast, right? This is the epicenter of the 21st century opioid epidemic. And as a result of that, we have a very large and significant number of problems associated with drug use in this state. But the flip side of that is that it really offers a lot of opportunities for us to do interesting and important research. So I'm going to walk you through what it looks like here, and hope that you get some ideas about where we could go in the future. So of course, the world started with a tremendous dumping of prescription opioids in West Virginia, 100 million opioids in pills in 6 years in a state that doesn't have 2 million people. You can imagine what kind of havoc that caused. And here's a slide from the Pulitzer Prize winning series in the Charleston Gazette Mail by Eric Eyre, where he actually got into the weeds and figured out exactly how many of these pills went where and which kind. And you can see that big red and somewhat smaller blue circles for hydrocodone and oxycodone were really heavily concentrated in the lower third of the state. So this part of the state is called the Southern Coalfields. That will tell you pretty clearly that this was an area that was very much dependent on coal mining, and has really, between the drug epidemic and the crash of the coal industry, suffered enormously. But you can see how many pills. We're talking the smallest dot is 2.5 million, and the bigger dots are almost 11 million pills. That's an awful lot of medication. And when the state clamped down on too liberal prescribing, that pushed a lot of people into buying their drugs on the street, and had a lot of people switch from swallowing pills to injecting street drugs. And of course, as a result of injection, we now have all of these fellow traveler syndemics, right? A syndemic are intertwined epidemics. And this is what our syndemics in West Virginia look like. Overdoses and overdose fatalities. We have the highest rate in the US and have for a decade, Erin, probably a decade. We trade back and forth with our neighbor, Kentucky, the highest rate of acute hepatitis C. We have been the state with the highest rate of acute hepatitis B for over a decade. We have the 4th highest rate of this hepatitis A outbreak among homeless persons and people who inject drugs, with 23 deaths. And I can assure you, as an infectious disease doctor, before this, you never see a death from hepatitis A. So this is acute hepatitis A on top of chronic hepatitis C in a population of people with really poor access to healthcare. We've had a number of HIV outbreaks, one scattered across the southern coalfields in 2017, a bigger, more concentrated one in Huntington, our 2nd biggest city, in 2018-19, and now we have a significant focused outbreak in Charleston, which is our capital. And I put a question mark there because I'll show you some data in a little bit, but because of the pandemic, testing for HIV is probably at a really low ebb. So we probably don't know the half of how much HIV we really have, related to the fact that the city of Charleston wisely, they thought, closed their syringe services program in March of 2018. We have the highest rate of babies born in withdrawal from maternal drug use, neonatal abstinence syndrome. We've had vertical transmission of hepatitis B, C, and HIV from mother to infant. And we've had incredible disruption of families and communities. We have over 7,000 children in foster care. And actually in some counties, this is 50% of the children. That's really, really scary stuff. So drug-related deaths in this country now exceed deaths at the height of the AIDS epidemic, which, as an ID doc who lived through all of this, just seems so amazing to me. But you can see the red line from the height of the AIDS epidemic in the mid-90s going across, and you can see that we have exceeded that every year for the last several years, and the curve is only going up. That is not a good thing. This is actually data that I found this morning on the internet, and this was Millennium Health. They call their report Signals. They released this today. They looked back at, this is a company that does a lot of drug screening. They looked back at the impact of the first 9 months of the pandemic and then compared it with the same period in 2019 and found that the adjusted positivity rate for urine drug screens was up 78% for fentanyl and 29% for methamphetamine. And that's countrywide, but that sure does mirror what we're seeing here in West Virginia. And then if you look at the impact of this pandemic on the entire United States in terms of overdose, well, overdoses dipped a little bit in 2018, but that was false reassurance because they've been on the rise ever since. And the 12-month period that ended in May of last year, we had over 81,000 drug overdose deaths. And this is the highest number of overdose deaths ever recorded in a 12-month period. It's frightening. So here is what life looks like in West Virginia. The top curve is all drugs. The middle curve in gray is overdose deaths due to opioids, and the bottom curve in dark blue is overdose deaths that involve methamphetamines. And you see that methamphetamine involvement is on the rise. And as I told you, 2018, not only were those data preliminary, but there was a slight dip in 2018, both here and nationwide, that was not sustained. So you'd like to get your hopes up, but you really shouldn't. And of course, overdose mortality is very much linked to poverty, and that big dark red blotch in the center there toward the East Coast, that's us, that's Central Appalachia. That's where all the age-adjusted drug overdose rate per 100,000 is the highest in this half of the country. And then you can see on the right, this is also an area of high poverty. And as I mentioned before, the worst hit part of our state is the southern third, the southern coal fields. And this is an area where the economy has been devastated by the crash and burn of the coal industry. So here's some heat maps. I took out the intervening years. It's pretty dramatic if you click through all of them, for a grant we wrote at the end of 2015. And this just shows you how fast acute hep C incidence has been rising in West Virginia. So of course, those dark blue counties on the left, those are part of the southern coal fields. And now on the right, just 3 years later, you see that it's ever more of the southern coal fields are now advancing into central and northern West Virginia. The dark blue county in the right-hand corner, that's Preston County. That's the county right next to us, where WVU is. And if you had any question in your mind at all as to whether the acute hepatitis C rate was connected or not connected to the injection opioid problem, here side by side, although they differ by a year, on the left is the heat map for the overdose mortality rate in 2014. Again, you see the southern coal fields are the area most intensely devastated, and on the right is the bottom half of that slide I just showed you. And right, hep C tracks with injection drug use. It's a very good marker of injection drug use. So here is, in one slide, superimposed and what's in parentheses is the state rank. And this is data through 2016, but hasn't really changed. So you can see, again, we're #1 for death by overdose, #1 for acute hep B. And in 2016, we were #2 for acute hep C, but then we were #1 again in 2017 and 2019. So as I said, this is something we trade back and forth with our friends in Kentucky. So HIV has been occurring across the United States among people who inject drugs. And actually, early on, HIV as an epidemic occurred among men who have sex with men, but also among injection drug users. And the proportion that was due to injection drug use really declined with the development and implementation of syringe services around the country, especially along the coasts. So the proportion of cases due to injection drug use has actually been declining since the early 90s, but it leveled off in 2014, and now it's on the rise. And one of these little circles is Cabell County, that's Huntington. That was our 2018 outbreak. This slide doesn't show you the new one in Charleston, but I'll talk to you about that in a minute. So this is an issue that is happening not only in rural spaces, but also in multiple urban spaces, right? Outside of Boston, King County is where Seattle is. And you see that very large pink dot, Scott County, Indiana. That was the wake-up call. There were 215 cases discovered in 2014, 2015, early 2016. There had never been a rural outbreak of HIV before. This caught everybody unawares, including the CDC. And the CDC went on to do an analysis of counties across the country based on the demographic characteristics of Scott County, and came up with a list of 220 counties at high risk for an HIV and or Hep C outbreak. And West Virginia's 55 counties, 28 or 51% are on that list. That we represent 13% of the risk counties nationwide. So what happens when HIV comes to a state that's really pretty under-resourced and largely rural? So West Virginia is the 10th least populated state. The largest city has less than 60,000 people. Most of my work has been done in the southern coal fields. So I give you, for an example, Wyoming County, which has 21,000 people, doesn't have a single traffic light, has 2 grocery stores, which actually for southern West Virginia is a lot, because the county just south of Wyoming, McDowell County, doesn't have a single grocery store. So you got to get in a car and go somewhere if you want a head of lettuce. The last coal mine and biggest employer, Pinnacle Mines, which had over 400 employees, closed in early 2018. So that was the last sort of prop, coal mine prop for this county. 50% of the children are in foster care. When my colleague Gordon Smith and I visited a middle school in Wyoming, and we got to see a 5th and 6th graders were asked to make a public service announcement. And so many of them, sadly, were about drugs. But they told us that the little girl who won the contest came from a classroom of 30 in which only one child lived with both biologic parents. So we're really seeing, tremendous social and familial disintegration as part of this. And Wyoming, of course, without a single stoplight, you're not surprised to know that it didn't have a single 4-lane road until just last fall, when the first 11-mile-long highway was dedicated. And I have to show this to you because, first of all, look how beautiful West Virginia is. And second of all, it probably doesn't surprise you that it took 30 years and $33 million to build this road. Look what they had to carve through. And this is what this part of the world is all about. It's a mountain from one end to the other. So let's go on to talk about new diagnoses in West Virginia. The number and proportion of cases of HIV in this state are really rising steadily. Actually, until the opioid and injection drug problem, West Virginia had always been a low prevalence, low incidence state for HIV. And almost all the HIV here was diagnosed among men who have sex with men. But that started to change, as I told you before. And, the typical number in a given year of new diagnoses to be about 75 or 77. I know these numbers sound like a pittance to people who live in states with a lot of people, but 77 is a lot here. So in 87, we already had, in 2018, we already had an increase in total number of cases to 87, and 45% were associated with injection drug use. The following year, we doubled the typical number from like 77 to 146, and 62% of those cases were in people who injected drugs. And the first 6 months of last year, which is only the first 6 months, we had 50 cases, and already 2/3 of those are associated with injection drug use. So the number and the proportion related to the drug epidemic is really increasing. So very recent data, in all of 2020, Kanawha County, which is where the capital Charleston is, had 35 injection drug use associated new diagnoses of HIV. All right, 35, it doesn't sound like much. However, if you compare this to the previous year in 2019, New York City, with over 8 million people, had only 36 cases of HIV in people who inject drugs. So according to the CDC, Kanawha County is now their area of greatest concern for a burgeoning epidemic. And here's a slide that the CDC actually presented to the Charleston City Council a couple of weeks ago. So out of the over 3,000 counties in the United States, 4 had more HIV diagnoses among people who inject drugs, and that's in the previous year, in 2019, than Kanawha County had in 2020. But 3 of these 4 have an average population of over 4 million people, right? Kanawha County probably doesn't have 100,000. And actually the 4th county is Cabell, where Huntington is. So if you look at counties with a population size similar to Kanawha County, the average number of HIV diagnoses among people who inject drugs in 2019 was less than 1. So we really have a big problem. So we have actually now, on top of all of this, a Senate bill that's been proposed. It's going to be have a hearing today at 1 o'clock that aims to make operating a syringe services program in the state virtually impossible. And I'm actually going to have to leave you all for a little while because I've been asked to testify at this hearing. But it's a pretty scary concept to get rid of syringe services in a state where Hep C and HIV and Hep B are just growing. So I'll end with or next to the end with this slide. This is never ceases to take my breath away. This is a poster that we saw in an abandoned storefront in Wyoming County. I didn't think in my whole life I've ever seen a poster saying we need foster homes, but this is what we're dealing with. So on that very cheerful note, I want to end by saying that although West Virginia has a lot of problems connected to the drug epidemic, there's also a lot of opportunities. We have opportunities for new CTN studies. We have opportunities for NIH and other federally funded research. The researchers and clinicians here are really committed to our work to both prevent and treat substance use disorder and its complications. And we are very open to collaboration, and we hope those of you listening will contact us in the future to talk about this. And later on today, you'll see a number of them in a video about the importance of this work and why they do it. And that is the end. And it is now my wonderful and intense pleasure to introduce Dr. Todd Korthus from Oregon, from the Health Sciences University, who is a friend and colleague. We were co-investigators together in, there we go, co-investigators together in a NIDA, multi-center NIDA funded grant that looked at problems in rural communities. So it's nicknamed the Rural Opioid Initiative. And he is also a longtime and highly respected investigator in the Clinical Trials Network. And I'm gonna let that, can you